The first talk is by Dr. Raj Narayan.
Good afternoon, everyone. Once again, thank you to AIOS for giving me this opportunity to share. It's not a new technique, but not commonly described or used technique. I'd like to acknowledge my fellow Khushbu in this particular study. So, complex retinal detachments and recurrent retinal detachments are not easy to manage. We have various options, peeling membranes, or doing retinectomies, leaving PSCL inside the eye, but still they have a very high failure rate. And after every recurrence and every resurgery, the chance of reattachment keeps going down. While a lot of other adjuvants have been described, antimetabolites and dexamethasone, and recently intravitreal methotrexate has been advocated and also being used by quite a few people, but it still requires multiple injections over many months, and the success rate is quite variable. And these injections have to be given repeatedly in these patients under silicone oil. And all these retinectomies in very, very difficult cases, uh, they do help, but they are also prone to recurrent detachment, especially these inferior retina under silicone oil, because silicone oil is lighter than water. All the PVR changes and recurrence under oil happen inferiorly, whereas if you use heavy density silicone oil, you are going to have superior recurrence of retinal detachment. Same thing which happens inferiorly will happen superiorly in heavy density silicone oil. So this is kind of a challenging case that I am going to describe, where it's a patient had an open globe injury which was repaired, and all the retina is incarcerated on one side into the corneal wound. What you are seeing here is bare RP and choroid. I hope it's visible on the screen. So this is how the retina is looking, and with a bimanual maneuver with forceps in both hands, we have to open this funnel, which is not easy. It took a long time to open this funnel, and these are the kind of tough cases where we are looking at different options, including the silicone oil and PFCL layered sandwich technique, which I am going to show, because these cases are prone to redetachments. This is a young boy from the Gulf who had Stickler syndrome. What you can see is this is all retina actually here. This is a funnel retina, and this is all bare RP, which you can see here. The retina is all on one side, and initially I had injected full PFCL in the vitreous cavity and left it for about 2 weeks. I thought I will leave it, but the patient or the boy presented in a week's time where the superior retina has detached under PFCL. So this is the GRT edge. This is the original laser marks in the bare RP, but the retina has slipped and detached inferiorly. And then I had to do a PFCL silicone oil sandwich. You can see inferiorly the edge of PFCL, superiorly silicone oil. You can see a nice reflection of the disc and retina in the inferior PFCL. So we have analyzed our cases. The first case I did was in 2013, and I have collected so far 34 eyes, um, and the kind of detachments were varied, including post-trauma, funnel RDs, recurrence under silicone oil. Two were done with endoscopic maneuver. The pre-op visual acuity was very poor, hand motions. Only two eyes had better than 2400 in this series. So the anatomical success rate after the sandwich technique was 96% in 1 week, and at last visit was 91%. The visual acuity on average improved by 3 lines, but still it was not great. At the end of the last visit it was logmar 2. But what you can see here is that 8 eyes had better than 2400 vision, compared to 2 eyes at baseline. So, some improvement in vision also is noted in these eyes. And this is that boy which I had mentioned who had sticklers from Gulf who had come. We had to do a lensectomy, and you can see the 360-degree giant retinal tear. You have to be very meticulous in these cases with the PVR. You have to do a thorough job of cleaning up any subretinal or epiretinal membranes, or if there is a retinal contraction, you have to cut the retina so that it can relax. So under PFCL, I used forceps as well as finesse loop to clean up all the membranes, and peripherally wherever there was a contraction of the retina, I had to do a relaxing retinectomy radially. And at the end, we left. I generally leave about 1/3 of PFCL in the eye, and the rest of it is silicone oil. So uh, this was what initially I told that the boy had superior recurrence, and then I had to take up again, and this time I did a little bit of retinectomy and injected silicone oil, and PFCL about 1/3 was retained, and this is how it was looking post-operatively. This is another case. Patient has a multifocal IOL, and this is under oil. Patient already had been operated with belt buckle, vitrectomy, silicone oil done twice outside. There is a break inferiorly, lots of PVR. So this surgery is being done under silicone oil. I am removing all the membranes and injecting perfluoron dual bore cannula under the silicone oil. Um, and aspirating some amount of subretinal fluid with a soft tip, and then again inject some more perfluoron under silicone oil. And as I said, generally about 1/3 of eye is left with PFCL. And this is how the pre-op under silicone oil. This patient had extensive PVR. She is also a high myope, and this is post-operative. This is another gentleman who had retinal detachment, choroidal detachment, uh, left PFCL in the eye, but in these cases, earlier I used to remove the PFCL in about a month and then completely fill with silicone oil. But in this patient, after removing the PFCL and injecting silicone oil, it redetached again. So I have left him with PFCL and oil sandwich now for many months, and these are some other cases. So in conclusion, splash is a promising option for managing complex retinal detachment cases with advanced PVR. We did not see any toxicity in these patients. Some of these eyes have had PFCL for almost a year, and I have left them in the eye. They also have severe hypotony, some of them, but it does not cause any toxicity. You just leave it, and whatever vision they have, they are able to maintain that. With that, I thank you for your kind attention.
Sir, Dr. Aryan. So great talk. Just one question. So at what stage will you ever envision removing PFCL, or will we just leave it forever? And does the thought come that at some point of time you will probably replace that residual PFCL also with oil?
Yeah, good question. So earlier I used to remove the PSL, as I said, in about 2 to 4 weeks time. It's not easy to remove the PFCL. One, it becomes very viscous like silicone oil, and it's like a heavy viscous liquid, so you can't aspirate, doesn't float up. So removing them may be difficult unless you really go in 2 to 3 weeks time. But now I don't remove it. I just leave it. It's safe. And these are cases which need chronic tamponade. This is not a routine surgical technique. You should not be using this in all recurrent PVRs or complex RDs. But where there is very advanced PVR, retinectomies are required, and you feel that these patients require long-term tamponade even with oil. So I just leave the PFCL and silicone oil in the eye, and I don't I don't remove them. I just leave it in the eye.
Can I just have one more question? And any thoughts on the fact that does it lead to more emulsification somewhere down the line of the oil, or any changes in the emulsification pattern?
No, I haven't seen emulsification either of PFCL and I use 5000 in these because I know these are long-term cases. Even if it's just oil fill, I leave them with 5000 and they don't cause any problem, and I haven't found any problem. The only problem is the mixture of PFCL and silicone oil. So you won't be able to remove it in many cases, even if you want to, after a month or so.
Thank you.
Dr. Shanmugam, any comment on this?
I haven't used this particular technique, but theoretically I find some issues like what do you make the patient lie down? So, because both are convex menisci, there is one rim of fluid between the two menisci. So that's something which can interfere wherever, if the break is somewhere in that, the fluid can go, that's what. And if the patient lying down, then the PFCL goes posteriorly if the patient lies down supine and the oil comes anterior. Sitting position, then the whole dynamics changes. So that's another reason. So I'm not too sure like if it gives me an added advantage. And sometimes when we have left behind inadvertently PFCL and silicon oil, they form one kind of a gooey mixture, which is extremely difficult to remove. And particularly if a little bit of viscoelastic also goes, it's extremely gooey and it becomes very, very difficult to remove. So right now, what you have said, I usually leave behind perfluorocarbon for about like a month, and subsequently either remove it if everything is fine or replace it with silicon oil. So I don't have a personal experience. I'm sure like Raja has shown that very good results, but in my hands it has not worked.
Yeah, I think it's good to use it during the surgery. I have used it during to be able to do laser, because otherwise, as you remove instruments, the PFCL starts coming out. If you have a layer of oil, it stabilizes the globe and allows you to do laser completely. And then you can remove PFCL at the same time if there is not advanced PDR, and fill up with oil. So I feel per-operative sandwich technique is also an option rather than just leaving it post-op only. Great.
Okay, thank you.
Thank you so much, Dr. Aryan. I'd like other speakers to come on the dais. Dr. Tinku, Mudit, and Mohit, come on the dais. Dr. Tinku will be the next speaker, Dr. Tinku Bali. She will be speaking on combined retinal detachment in proliferative diabetic retinopathy.
Laser pointer. So good afternoon, everyone. I'll be speaking on a very challenging complication of diabetic retinopathy, that is a combined retinal detachment. Now, a combined retinal detachment is a combination of a tractional and a rhegmatogenous retinal detachment. And I feel it's one of the most challenging situations for a vitreoretinal surgeon, because in this situation, you not only have to safely remove the adherent fibrovascular tissue, the retina is thinned out, ischemic, and mobile. And at the same time, it's imperative that you do not cause any iatrogenic breaks or cause very minimal iatrogenic trauma to the retina. So a combined detachment has retinal breaks in association with fibrovascular proliferation, which could be of varying severity. These retinal breaks are likely to appear when the tractional force acts on a thin retina in a PDR patient, and they are generally located adjacent to the proliferative tissue or even near previous laser marks. So whenever you're doing a laser, it's very important that you keep some amount of distance in between your TRD and the laser, otherwise it could lead to a combined detachment. So combined detachment, when you see a TRD converting into a convex configuration, you suspect that this is a combined detachment. A combined detachment would not follow the Linkoff's rules. It would usually reach up till the ora serrata, but in some areas it may not, because it may be limited by the laser that you've done. It may be limited by the fibrovascular proliferation. So it could just be any kind of a configuration. An important thing that would make you suspect a combined detachment would be that the subretinal fluid would extend beyond the fibrovascular proliferation. In a TRD, it would be limited to the area of traction, but here, as you see there on the nasal side, the fluid is where there's no traction. You'll also see fluid in that area, so that makes you suspect it's gone into a combined situation. These breaks are slit-like, they could be round, they could be oval, they could be sieve-like. Sieve-like when there are multiple breaks along a very, very, a very heavy laser that you've done, that could also cause breaks. They could be at the base of a fibrovascular proliferation, and many a times they are hidden under the retinal folds or covered by the fibrovascular tissue. So many times you will not be able to preoperatively locate a break in spite of all efforts. And a macular hole could also cause a combined detachment. Another thing that would make you suspect a combined detachment is when you see subretinal bands in a tractional detachment. So subretinal bands and also subretinal hemorrhage, they are very key giveaways that this patient has a break somewhere. The risk of a tractional detachment converting to a combined detachment is, of course, a long-standing TRD. Heavy laser, as I mentioned before, if done near the edge of a tractional detachment. Anti-VEGF injections, because they induce fibrous contraction of the proliferative tissue. And, of course, iatrogenic, when you're operating a tractional detachment and you induce a break. That was also called a combined detachment, where your retina starts becoming bullous. So this is a patient who had a tractional detachment. Over the course of 4 years, one day he came back with a sudden diminution of vision, and here you see in the inferior part, you can see that he has a combined detachment now. That's the rhegmatogenous component. So the types of combined detachments could be active fibro, that could be a detachment which has active fibrovascular tissue, or it could be an avascular fibrotic tissue. This is the late chronic cases where the tissue has become avascular. So the visual outcomes are, of course, better in cases which have active fibrovascular tissue, because the retina is still not that ischemic. And if you treat it preoperatively with anti-VEGF, then you get good visual outcomes as compared to the avascular fibrotic tissue presentation, where the retina has become ischemic, thin, friable. Now, in the preoperative workup, a good patient counseling is imperative, because you may be able to get anatomical attachments in many situations, but the visual outcomes may not keep up with your anatomical. As I mentioned, the retina is thin, ischemic, may have been detached for a pretty long time. So please temper the expectations of the patient. Do not give them very high hopes, because you, in spite of a very well done surgery, the visual outcomes may not be that great. Laser the untreated areas before the surgery. Do look out for the breaks if possible, because in your head you'll have a better idea. So if you can search for the breaks very meticulously, they may be hidden, like I mentioned. A preoperative OCT helps to give you the configuration of the retinal detachment and also prognosticate, especially when you look at the outer retina and see the external limiting membrane and the ellipsoid zone. They would give you an idea on how to prognosticate the patient. So pre-op anti-VEGF, of course, definitely helps in whenever there's a lot of fibrovascular tissue. So in the fibrotic cases, like I showed you, you do not need to give anti-VEGF injections. But if there's a lot of fibrovascular proliferation, as you see there, 3 to 4 days before surgery is what I do. Now, there are different variations. Different surgeons have different views. Some like to give it a week before, some 1 day before. But I think 3 to 4 days is a good, a good number of days. Do not, if you feel that the patient will not be able to come for surgery, or if the patient is too ill, then do not give the anti-VEGF, because if you keep a very long gap between your surgery and the anti-VEGF, the tissue becomes really fibrous and thick, and it may become very difficult to identify the planes if you give a very long interval. So make sure your patient is fit for surgery before you give your anti-VEGF injection. So the basic principles of the surgery, of course, are to ensure media clarity. These are very challenging surgeries where, it's very critical that you have very good visibility. So if you have to do a cataract, even small lens opacities could hinder your surgery. So you could do a prior cataract surgery. A combined surgery can also be done, but I think in such cases, it would, create a very long surgical time for the patient. Also, the cornea sometimes becomes edematous on table. So my preference is to do a prior cataract surgery and then take up these patients. You release the anterior posterior and the tangential traction, remove all the epiretinal membranes and the posterior hydroid. Be sure not to create iatrogenic breaks, because in this case, there's a lot of fibrovascular tissue on the retina. If you create an iatrogenic break, it is important that you clear off the area around the break of all hyaloid tissue, all membranes, so that you do not have so that the retina settles and you do not have a redetachment. It is important to control the operative hemorrhage. You can raise the bottle height, but what many times I see is that, the bottle height is increased and the assistant or the surgeon forgets to bring it down. In these cases, the optic nerve is very fragile and ischemic, so please keep a watch on the bottle height. If you've increased the bottle height to prevent hemorrhage, then after 2 minutes maybe, you should bring it down. So like I said, the break recognition sometimes is difficult, but when you see fluid coming out of it, the Schellen phenomenon, that is the time when you can identify the break. And whenever you see there may be more than one break in a particular case, and it is important to relieve the traction around the break. To reattach the retina, you can do a fluid air exchange, a fluid air exchange. You can also use PFCL. The key is to find the right plane of dissection, and the inside-out approach works well, where you find a plane at the optic nerve and then you start dissecting towards the periphery. You use segmentation, delamination, and bimanual techniques can also be used. So I'll just show you how you... So at the optic nerve, the retina is the thickest, and when you create a plane at the optic nerve, there is a very less chance that you'll create a break in the posterior retina. So the optic disc is a very good place to create your plane, and then you can dissect out the tissue towards the periphery. So this is a case of combined detachment. So here, like I mentioned here, you segment all these attachments to the retina. So at this time, the retina is not very mobile. It's easy to segment these attachments. 27 gauge cutter works very well in this because it's thin, it can easily get in under the retina. The port is located right at the tip. So the cutter can be used to delaminate as well as segment, and if there's a bleeder, you can just press with the cutter itself to stop the bleeding. Here you see this sheet of tissue. Sometimes there's also vitreous schisis, so after you've removed these membranes, be sure to stain with tricot. Also, tricot use should be very little in quantity because sometimes it can go inside the break also, since the break is under traction. And here you see the fluid gushing out. That was the break which was at the border of that fibrovascular proliferation. Preoperatively, I could not see the break. And you see this fluid exchange being done and the retina being settled. Sometimes when they're very thick fibrovascular and very adherent fibrovascular proliferation, so for every case, your surgical approach has to be different. It has to be tailored to the patient's presentation. It's like getting a sticker off from a bottle. Sometimes it may come out totally. Sometimes you may have to scratch it on the surface. So every patient behaves differently. And bimanual dissection is a good technique to know and to practice whenever these membranes are very adherent. So for that, you have to put in a chandelier light. You can put in either one chandelier or two chandeliers and then lift up with the forceps and cut with the curved scissors. So these scissors can be used to cut as well as to create a plane under the retina. When you keep the scissors closed, you create a plane underneath and then identify the pegs and then go on cutting those pegs. PFCL has been used in this case. Whenever you're using PFCL, be very careful because these breaks are under traction, and in such situations, it's very easy for the PFCL to migrate under the retina. So subretinal, so stay well away from the breaks whenever you're using PFCL in these conditions. So this is the case I showed you in the beginning, which is settled after surgery. So post-operatively, of course, you need to identify the breaks. You can do cautery around the breaks and do a very good pan-retinal photocoagulation. And for tamponade, you could use gas or oil. And with modern instruments and techniques, the anatomical success rate is high in these cases. Earlier, they were very challenging situation to manage. But again, as I mentioned before, the visual outcomes may not keep pace with your anatomical outcomes, and that has to be told to the patient. Thank you so much.
Thank you, Dr. Tinku. I think we'll do the discussion afterwards because we overshot the time. Tinku, you can come on the dais. Next talk by Dr. Mahesh Shanmugam on advanced proliferative vitreoretinopathy.
Thank you. Thank you. Thank you, Dr. Mallika. So let's look at my strategies in managing extreme PVR. So the initial step is to enter the eye and visualize. So most of these patients will have an anterior PVR, which will pull up the retina. A regular infusion cannula is likely to go subretinally. And in these patients, once it becomes bullous, it's extremely difficult to operate. So I would usually put a 6 millimeter cannula, and despite which you may be going through the retina, and the fibrous tissue on the retina around this cannula should be freed, so that like the cannula is inside the vitreous cavity, facilitating the surgery. Otherwise, if it's a subretinal infusion, then condition becomes worse even before we begin, and it becomes extremely difficult to handle. Similarly, visualization has to be of paramount importance. So if there is a cataract, we would remove it, and if there is an intraocular lens which is obscuring the view and there is anterior PVR, then I would probably remove the intraocular lens before we go inside and operate. But in case like the media is clear, as in this case, better not to remove the lens, because the barrier between the anterior segment and posterior segment is essential. So here it's a young patient and the lens is clear. In a young patient with the lens being clear and thin, with appropriate dissection, appropriate depression, we can go up to the pars plana and remove the fibrous tissue also. As you can see here, you can use a cotton bud applicator to depress, and you can clear the membranes even up to the ora serrata with appropriate depression and the manipulating the suction in the vitreous cutter. And before instilling perfluorocarbon liquid, pre-retinal membranes have to be removed. If the pre-retinal membranes are not removed, and if you put perfluorocarbon, it's likely that the perfluorocarbon will go under the retina, because the whole break is kept lifted up because of the PVR. So here we can see a posterior pole fixed fold. The posterior pole fixed fold was, the membrane which was holding it up was removed. Then perfluorocarbon has been placed, and we kind of fill the perfluorocarbon in a graded way. So fill it up, to peel the vitreous, cut it, then put a little bit more perfluorocarbon, reattach the posterior retina, peel the vitreous, and then like in a graded fashion, we just keep peeling the vitreous and keep adding more and more perfluorocarbon and taking the vitreous dissection almost up to the ora serrata as much as possible, doing a good vitreous-based dissection. So here we have done a vitreous-based dissection. This patient already had a traumatic iridodialysis, which is also required. So now we have removed the perfluorocarbon and doing a fluid air exchange, reattaching the retina, and then treating the periphery with the laser photocoagulation and using silicon oil. So here we need to distinguish between pre-retinal and subretinal PVR. So here we have placed an encircling band, and the patient had a complicated cataract, so we removed the cataract. Here you can see a posterior closed funnel. So here we are removing all the pre-retinal membranes using triamcinolone to identify the fine membranes and removing it. And with an appropriately placed retinotomy, the subretinal membrane is being removed. The appropriately placed retinotomy would be somewhere in the mid equator, and in the same meridian of the sclerotomy, and the dominant hand. So if your right hand is the dominant hand, the retinotomy should be somewhere in the mid equator on the same side. So you can see that through this we can remove the subretinal and peripapillary membranes, and there were some membranes on the temporal side also, so which is also being removed. You can see that the light pipe is being used like a pivot. So the membrane is drawn across the light pipe so that it doesn't extend the retinotomy, and the retinotomy remains small, and the SRG comes out through that. So we remove all the pre-retinal membranes and then look for the subretinal membranes and remove it. So this was the net result of this patient who had a closed retina. And as I mentioned, like here, we have to remove the pre-retinal membranes before attempting to remove the SRG. So this is a high myopic patient. You can see the infusion cannula in the subretinal space. We cleared the retina. So we've taken all kinds of pains to remove as much of the pre-retinal membranes as possible. You can see there is a peripapillary napkin ring, and there are fine membranes which are immature PVR, which is being identified and removed. And then you can see the forceps in the subretinal space trying to remove the napkin ring. So snapping the napkin ring and removing it, hoping that the posterior funnel opens up, but the posterior funnel is still not opened up. Then we find that despite looking for it and removing it, we still have one area of the pre-retinal membrane which we have not identified. We have removed it, and then one more subretinal band in the inferior space, inferior retina, which is being removed. Following that is when the retina opens up. So despite our search for it, there can be membranes which may be left behind. So we have to look for it appropriately and remove all the pre-retinal membranes and the subretinal membranes. This retinal detachment doesn't look extreme in the sense like the retina looks mobile and there's one giant retinal tear, but actually these are the more difficult cases because these are immature PVR, the membranes are not well defined. These are the ones which are difficult to identify and remove. In these patients, I would usually identify the membranes by staining the ILM and removing the ILM posterior pole, and that kind of gives us a handle to identify the membranes and remove it. So here you can see keep removing membrane after membrane, and it's immature PVR, so the margins are not very, very clearly defined. So you can see that there is a cortical vitreous which is extending posteriorly. Here again you can see put perfluorocarbon, and under the perfluorocarbon also remove the membranes, and remove the perfluorocarbon, then some more membranes, remove them as well. So there are extensive membranes, and after that, like fold the retina and see if there is any subretinal membranes. And after removing all the membranes, the retina is reattached with PFCL, and laser photocoagulation oil is used. And when do we do relaxing retinectomy? When the anterior retina is foreshortened and we are not able to peel, is when we cauterize and do like retinectomy. So once we do the cautery, you can see this radial retinal folds happening in the anterior part of the retina. That indicates the attachment of the vitreous base, and that's exactly where we have to do a circumferential retinectomy. So the retinectomy is done posterior to the vitreous base attachment up to where we can peel, and then reattach the retina. So this is an extremely complicated appearing PVR, RD with PVR. You can't make out anything, and it's a closed funnel. There's hardly any hyaloid separation. So we're just about making one opening. This must also be a very high myope. So there is no posterior vitreous detachment at all. So we are trying to see if we can create some kind of a plane from where we can operate. We're just not able to. And using the cutter to insinuate between the retina and the hyaloid. So the funnel is somewhat opened up. So you can see very thick membranes bridging across the retina. So, and now we are using a bimanual surgery of using two forceps to identify the membranes. We can use two forceps to hold the membrane and tear them apart also, and thereby not transmitting the traction to the retina. So in the absence of a PVD, these are immature membranes plus mature membranes. We're trying to peel all the membranes, and despite which you can see there is a posterior fixed fold also. And in the process you have multiple breaks happening. Now we have done a fluid air exchange, and you can see that the retina the air has gone the subretinal space temporarily, ultimately making us resort to a retinectomy. Finally, managed to attach the retina with multiple breaks, but. So GRT in young patients may not have a PVD or an adherent vitreous. So this is one such patient. Like Dr. Raja showed a Stickler's syndrome, but like Stickler's in children may not have a posterior vitreous detachment at all. So here you're struggling to induce the PVD as much as possible, despite which just about beyond the arcades is how much we are able to induce the PVD. Beyond that, like we're just not able to induce the PVD, despite all struggles. Now, when we put perfluorocarbon, everything looks hunky-dory, that like retina looks attached. There are a few breaks in the periphery, but everything looks fine. Extensive laser was done, and all these breaks were in an attempt to induce the PVD, but then about a month later, see what happens. That residual vitreous which we left behind has contracted and lifted up the retina, and you can see the membranes are a little bit more well-defined, and the perfluorocarbon has broken to multiple bubbles. Now you can see the residual vitreous has formed multiple membranes, and painstaking removal of these membranes as anteriorly as possible, trying to save as much of posterior retina as possible is what we are trying. You can see these are all vitreous which could not be identified and removed during the previous surgery because there was absolutely no hyaloid separation. Now we remove it as much as possible, all the membranes, then reattach the retina and then do laser photocoagulation. So other considerations, extreme PVR, belt buckle or scleral buckling. If planning a 360-degree RR, there's no need for belt buckle. Inferior breaks where vitreous cannot be peeled anteriorly, then I would do a scleral buckle, in addition a solid silicon as well. Temporary PFCL tamponade is something which I use particularly in children where they cannot maintain a position. Inferior breaks and retinal detachment, I leave it in place for about 4 to 6 weeks. Then either remove it or replace it with oil. Pharmacological adjuvants, I have been just about using it in a couple of patients, but no personal experience, and adjunct methotrexate seems promising. Thank you so much for your kind attention.
Excellent videos, Dr. Shanmugam. Any comments from the panel, questions? Dr. Verma, anything for Dr. Shanmugam on this?
No, excellent videos. In such extreme PVRs, I tend to, use a buckle because lest I am not very keen for doing retinectomies, so I support them on buckle, high buckle. So, and maybe oil and oil exchange if it's a one-eyed patient as a salvage this thing. So instead of, doing extreme retinectomy, we do resort to retinectomy only in very, very extreme patients. I depend more on buckle rather than these things.
Yeah. And do you have any preference for a particular, like high density oil so that the emulsification is slower? Do you use 5000 oil preferably in extreme PVR?
If there is hypotonia and I am not likely to remove the oil is when I would use a 5000 oil. Otherwise, it's usually 1000 oil and then remove it within about 3 months' time. And as I mentioned, of late in very, very severe PVRs, I use perfluorocarbon. And in those patients where the retina, despite membranes all being removed, despite that there will be some folds which are not ironed out, I wouldn't do a laser photocoagulation at that point in time. So leave the perfluorocarbon, ask the patient to maintain a supine position, let these folds iron out, and as a second step, I would probably think of doing a laser photocoagulation and replacing this with a silicone oil.
Thank you.
Sir,
Sorry. Other thing which we have started increasingly doing is, leaving, like Mahesh was saying, about perfluorocarbon liquid inside, and then laser, and then after say 2-3 weeks, do a oil, this PFCL oil exchange. That does help. But using high density, I don't think so. Only in one-eyed hypotenuse eye where we have to, keep it, then we use 5000.
Thank you.
I had a question actually.
Mike.
Yeah.
Meanwhile, can Dr. Mohit get his slides ready?
Any experience with the use of methotrexate for preventing PVR or any other adjuvant?
As I mentioned, I've just about started using, but not like the schedule which Dr. Naresh or which the studies have shown. Almost every week, that's something which I have not done. So I may be using methotrexate at the end of the surgery, but what we need to understand is like there is no substitute to peeling the membranes and removing everything properly. So relieving traction. So after that, we can use methotrexate to decrease the risk of a PVR, but methotrexate is not a panacea for inadequately done surgery.
so what about dexamethasone implant?
I have not used dexamethasone implant. I have sometimes earlier left with the triamcinolone inside, which is cavity. But studies have shown that like steroids alone don't seem to take care of the PVR. So methotrexate seems to be the most promising. At least there are 2 studies, one from Dr. Naresh and one from, I forget the other person's name. So these 2 studies have shown that like methotrexate seems to work, but the schedule is a little bit taxing.
Yeah, it's almost every week for the first 1 month and then every 2 weeks. Yeah.
So how far
This
do
is
you
the last
peel
comment,
the,
last
so
question.
how far do you peel the ILM for all those immature membranes that you show?
It's kind of a handle in the sense like I peel it up to the arcade, then you'll start seeing the immature membranes. So that kind of gives us a handle to start peeling from there. That's what I would use.
We'll go with the next talk by Dr. Mohit Dogra.
Thank you, ma'am, and thank you for the opportunity. I'm going to be speaking on retinal detachment with giant retinal tears. And since this was a complex RDK, session, I did not go down the route of actually telling you what a giant retinal tear is, how you conventionally would manage it. I'm going to just talk about 5 different aspects. So certain considerations which we might have in giant retinal tear patients. Some of them are not set in stone, some of them are controversial, some of them the jury is still out, but I still want to actually discuss some of those points. So I'm going to be starting with iatrogenic giant retinal tears and what we all should be aware of that, typically as we are surgeons, if you remove foreign bodies through sterile incisions, and any time you want to try and increase the size of the incision and use your MVR or whatever be your choice of instrument to get the foreign body out, you can get a port-side a giant retinal tear. Phacophragmatome, big boon for us for hard cataracts at the back of the eye. You can try and get them out, but please ensure that the vitreous is out because phacophragmatome does not have a cutter. So if you engaged vitreous with it, you can very well, with the high suction not realizing, and maybe with the cornea not being as clear as you'd want to be, have a giant tear on the periphery. Anterior segment colleagues, or if you're doing combined surgery, fishing, going with all kinds of instruments to try and get your drop nucleus out, or some of our posterior segment, our anterior segment colleagues like to do a PAL, a posterior assisted levitation. By God, I hate it. I've actually managed more giant retinal tears because of this than I think one should. So if you do not know how to do any of these, only if you've seen them in conferences, please do not attempt them. If you're doing peripheral vitrectomy in endophthalmitis and you're going really gung-ho and you want to go all out into the periphery and do maneuvers as you would do in the reg RD, you're inviting trouble, and getting giant tears post-operatively is common. You can do, if there is something that we must be aware of, typically MIVS, big boon, 23-25 gauge cannulas, but if you have formed gel vitreous, especially in your main port, you can get peripheral vitreous along with some exudates, or in cases of vitreous hemorrhage, go into the trocar cannula, and then and sometimes, getting your instruments in and out can be difficult because the minimal space is actually taken by the vitreous that's gone in. And if you try and yank your cutter or whatever be your instrument out, you can actually cause the entire retina there to rip. And a case which generally has a good prognosis would turn out into something that requires a tamponade, maybe even oil. You can have port site in cases of interior PVR or cyclitic membranes where the pars plana anatomy is altered and it's entirely actually shrunk down. And if you want to enter at 2 or 2.5, 3 or 3.5 millimeters, there might not be any space, and you can go through the retina and cause a giant retinal tear or dialysis. And you can have misdirected cannulas, your infusion cannula, which is actually infusing into the subretinal space. And if you do not realize, it can keep ballooning up, and you could, sometimes, just land up with a giant retinal tear. I'll also like to show 2 small videos of what could happen. This patient had a traumatic nucleus drop, was planned for a combined lensectomy VIT and a glued IOL. So this is in prep for the glued IOL. So the flap on the right was actually well made. The one on the left wasn't quite as well made. It actually, the depth was fine, but while dissecting, as you will see now, if it's visible there, yes, you can see that, one's gone all the way into it's gone full thickness, and there is exposure of the CDD body with the knuckle of the vitreous coming out. And while there was prep going on for the IOL, you can see that there is such a big stream of fluid coming out that at the port site, you can also see the change in reflex because there's a giant tear happening there. So a rookie mistake, but something that can happen and which could jolly well have been avoided from the get-go, and you can see that's a giant retinal tear there. This is another patient, was actually ophthalmos, and you can see that there was actually 17 millimeters corneal diameters, was planned for a lensectomy, vitrectomy, and retinal and actually RD surgery. After lensectomy was done, you'll see that the residual anterior capsule will soon be attempted to be removed with a forceps, and while pulling, and this has been slowed down, you'll see that because here the anatomy is altered, ophthalmic eye, differential growth, you have zonules which are inserting all the way posteriorly up into the vitreous base. Not only was the anterior capsule removed, it actually led to a giant retinal dialysis there. So please watch out in these eyes. These are all causes and all things that we can avoid. This is iatrogenic, giant retinal tears, some of which we can avoid and we should be mindful of. As far as GRD prophylaxis is concerned, I think fellow eyes of non-syndromic giant retinal tears, one must laser white without pressure areas, lattices, holes, and tears. Fellow eyes of syndromic giant retinal tears, at least that's what I do. I tend to follow the Manchester protocol. I laser 360 degrees from aura to the equator, one burn width apart, so all the way across equator to aura, 360 degrees. You treat both eyes of genetically confirmed sticklers type 1, type 2, and again, this is to prevent giant retinal tears and hopefully retinal detachment in both eyes in families in which sticklers is known. And you can also try and look at a broad encirclage as prevention. Mind you, if you do want to go down that route, a mere 240 band will not suffice because you need a broader indent, so a 220 or a 242 widely. And this is, to prevent and counteract from the exterior actually contraction of the vitreous base. This is again just one case. This patient had a giant retinal tear in 270 degree, which was fixed. The fellow eye underwent prophylactic 360 degree aura to equator laser and was confirmed, of course, later. Was confirmed to have sticklers, and only then was prophylaxis done. But prophylaxis is a must because it's been shown that it reduces the rates of giant retinal tears in the fellow eyes to almost to less than 3%, as opposed to 50% in the natural course over 5 years. As far as encirclage, so typically not recommended in giant retinal tears with greater than 180 degrees. It can be considered in patients where the lens is clear and you want to try and preserve it and not combine it with either lensectomy or cataract surgery. I definitely try and do it in pediatric and syndromic eyes if it's 180 degrees and lesser, and for fellow eyes in Stickler syndrome patients. I'll just show two patients here. This is a young boy, actually one-eyed, came during COVID, had a nasal 180 degree giant tear, and a broad element has been put, as you can see, and was actually managed with that for a high buccal indent syndromic patient. The other, again, he was a known patient, he was a known family history was there, the known Stickler syndrome, had a fairly good prognosis, just macula off, giant tear, small giant tear about 100 degrees, was managed with gas actually. And, but again, to support that, and because I wanted to put in gas, a broad element was put in these cases. So it's not something that should completely be put into the bin, but should be used in patients of syndromic giant retinal tears, pediatric patients, and also in patients with giant tears 180 degrees and lesser, especially if the lens is clear and needs to be preserved. As far as posterior vitreous detachment is concerned, as was also shown by Mahesh sir, conventional teaching states that PVD is present in GRT. Yes, for the most part, but please don't assume or presume it to be there, especially in traumatic posterior giant tears, because there the pathology is there was trauma and the retina was just cut like that. So there was no time for the vitreous to get separated. And in pediatric syndromic giant tears, as Dr. Mahesh had shown. And if you have that, again, as Sir actually showed, these progress and they don't do well with just a single primary surgery, and a lot of times will require very meticulous, time-consuming bimanual dissection to try and get the hyaloid off. And if you're unable to induce PVD in giant retinal tears, which you might in these, in this subset, a wide ILM peel should be done. Easier said than done, but can be done under PFCL. Just ensures that you can try and remove at least some semblance of hyaloid and do a short-term PFCL tamponade with a planned resurgery within the next 1 to 2 weeks. Just going to show, skip the video and quickly show another, a patient like that underwent what seemed like routine surgery for a giant tear, and presuming that the hyaloid was off. It wasn't. 2 weeks later, you can see that's the edge where the laser happened. The entire thing's contracted. There was subretinal PF. I'm going to skip the video for the want of time. And finally, the huge membranes were removed. Just goes to show that if you do that, please do not presume the presence of a PVD in giant retinal tears, as was previously thought. You must try and stain, and for the most part, you will have a PVD, but not in all. And in cases that you do not induce a PVD and you put in oil, they come up with very bad, very aggressive epi and subretinal PVR, with a more extensive surgery required the second time around. As you can see here, this is a traumatic posterior giant tear with a with the impact site, and you can see the entire retina is actually crumpled up there, and no PVD at all, because the etiology is trauma and not the separation of the vitreous. And you could, we could open the eye, the pucker up, and this patient did fairly okay. But just to show that, please do not presume posterior vitreous detachment in all, giant retinal tear patients. And I'm going to finish with this one slide and not show the other two cases for want of time. PFCL, big friend, we don't have to lie on our back, and the patient doesn't have to be suspended up in the air and us to do all these gymnastics to try and fix giant retinal tears now. Heavy liquids, big boon, completely revolutionized, giant retinal tear detachment surgery. It can also be used as a short to intermediate term, tamponades, as Dr. Raja might say, even as, sandwich technique for time immemorial. My take on that is not not as favorable as his. However, you have to be mindful of it going under the retina, of you causing, high pressure, of you causing it to actually go under the retina and actually have. Again, this patient was referred to me from Delhi. Just going to finish with this. Bilateral, the right eye was fixed in one of the leading centers here. The left eye had a detachment, and this was, mind you, right after the legendary Dr. Steve Charles actually had given his lecture on use of short-term PFCL for giant retinal tears. And someone who was, I think, way more smarter than he or she thought he was, actually went about putting in a PFCL tamponade for a superior giant retinal tear. For my mind, the only contraindication, the only reason, the only patient that you should not be putting it in, and that's what you saw there. So you have PFCL filled eye, which is in front of the retina, behind the retina, and the superior giant tear, which could jolly well have been fixed conventionally, now actually ended up requiring a more extensive surgery, retinectomy, and whatnot. And as you can see there, also sutures for trying to retain silicone oil at the back of the eye with very poor functional outcome at the end. So please, if you want to try a new technique, if you want to try and use PFCL as an intermediate term tamponade for giant tears, not for patients who don't have PVR and have a superior giant retinal tear. Definitely not for them. Thank you.
Very good videos. What is your personal take on band for support for a GRT? And do you do cryo sometimes if you feel that the laser you may not get burns sometimes?
Yes, absolutely, ma'am. So I'll answer the second part first. So I actually cryo the horns generally, ma'am, in all patients with a clear lens, in which I'm not sacrificing the lens. I do not want to try and go all the way up, into the periphery, even with external depression with laser. So I will laser the rest of the part, but the two horns of the giant tear I will cryo. Yes, as far as a low indent or a high indent band is concerned, depending on what the case is, for all patients of 180-degree and less, extent of giant retinal tear, I put in a low 240, a low height, 1 millimeter height 240 band, and that's the only time I actually measure my 240 band, and I don't tend to, because I want a 1 millimeter height. For all syndromic giant tears, ma'am, I tend to look at a broader element, again, depending on what the extent is. And typically, the idea is to, because I presume that I will not be able to do a great job removing the vitreous as I will be in non-syndromic eyes. So I want to try and, support the edges, and if it's not too posterior a giant tear, even the edge of the giant tear with a broader element. But otherwise, for your myopic, for elderly, for traumatic anterior giant retinal tears, no band.
Thank you so much. Thank you. Dr. Verma, for the next talk, please. Macular hole retinal detachments. Yeah.
So I think one of the common themes that has emerged from all of the talks till now, even Dr. MPS's talk or Mohit's, is the fact that a good adequate removal of vitreous and good removal of membranes. There is no substitute to that. For the cases that Mohit had also shown, the ones where there was an iatrogenic GRT, one of the most common factors is when you end up pulling upon the vitreous without completely removing it. So removing foreign bodies without having removed or shaved the entire peripheral vitreous. And in the process of removing foreign body, you end up having vitreous getting entangled over there, which pulls it up. In doing lensectomies again, when vitreous probably comes into your frags, I think Sir's talk said ready. So the most important thing is a good meticulous removal of peripheral vitreous to prevent those GRTs from occurring.
Thank you, Malika, for asking me to be part of your course on complex detachments. You see, like Mohit was talking about, vitreous is the biggest enemy of a vitreous surgeon, but you see, peripheral vitreous is sometimes problematic. So I'll be talking about situations where macular hole and detachment have troubled us. You see, I remember one patient, he was a police officer, and we were operating for him on Reg RD. It was a bullous detachment, and the process I thought is very good. And once we went inside and, after core vitrectomy, put PFCL, to my dismay, I found a big macular hole there. And the reason I got slightly upset was not because of difficulty of surgery, but about the prognosis. Because this serving commissioner of Delhi Police, we had to explain him that why vision may be subnormal. So since that day onwards, in all detachments, irrespective of whatever, I do an OCT beforehand. So I'll be talking of basically two situations only, where there is a pure macular hole detachment, and the other part, I think, where the reg RD plus tear plus macular hole. So this is one video of the same gentleman which I was talking about. So we go ahead and do a core vitrectomy, and after that, this is a bullous detachment. Has become slightly shallower than when I saw him before operating, and you see a macular hole there. So you go ahead with the usual, vitreous dissection, and after that inject the PFCL third hand like this, and then again complete your vitreous shaving in the periphery, and remove the PFCL bubble, and put BBG dye. I could have put BBG over the PFCL, but I think this stains better than that. A lot of people do the reverse also. And after having stained again put a PFCL there till the arcade, and then with direct pinch and peel technique, try to get hold of the ILM, which is a slightly different feel than a routine macular surgery. This ILM, here we did peeling only. We completed 360-degree macular rhexis here. This ILM, because of the weight of the PFCL, tends to scroll down and roll down because of the heavy PFCL. And once a sufficient ILM peel has been done, like this is scrolled up here, then you go ahead with in the first go itself, try to peel off as much as you can. And then sometimes I will slightly massage the macular hole so as to approximate these edges. And then do a usual, base dissection, retinotomy, and gas injection. This is the second patient which is only macular hole RD in a myope. So you could have in a non-myope, but in myope, but more commonly. And this was the OCT of this patient. You see the hole and a detachment there. So here the situation, this is a video of this lady. So again, go ahead and, do a core vitrectomy. Then I depend a lot on tricot assisted. In a high myope, it is mandatory sometimes to check once or twice by injection of tricot. So this tricot, once we had sufficiently done it, so I thought this tricot is now free flowing and entire vitreous is out. So you see how this is coming out, but in the nasal part on the temporal, we engaged a last membrane of this, last leaflet of tricot. This was the after second injection of tricot. And so the entire vitreous sheet was still there. And caught hold of with the help of suction only of the vitreous cutter. And this entire sheet thankfully came very nicely. Took all across the optic nerve till the time we could pull it up behind the lens also. So this, I think, is a very relieving step for a vitreous surgeon that entire vitreous sheet has come out. If not, you could have sleepless night. That now you trim the peripheral base, and then I tend to do a extra macular retinotomy. I don't drain through the macular hole, so I will flatten the retina first. Only macular hole RD, so I'll do a small retinotomy just outside the arcade, and then flatten the retina with the help of PFCL. And because the contrast in the posterior pole in a myope is not very good, and it's only a macular hole detachment here. And then BBG, then again PFCL. You see this is a contrast which is affording entire posterior pole is white. So then you begin your ILM holding or ILM this direct pinch and peel in the periphery, in the slightly normal area where you can see the underlying choroid, and then take it towards the macular hole. In such high myo patients, instead of peeling, normally I create a multi-layered flap rather than all across peeling. So don't lose the sight of the edge, because if in a poorly contrasting space, you may be caught that you cannot. So this retina also was slightly getting lifted up. So then we drained it from that iatrogenic hole which I had created outside the arcade, and then did a gas injection. So this was the pre-op and post-op of this patient, lower one pre-op and upper one post-op. You see the maculopathy of myopic tractional maculopathy here. But the posterior pole became flat and patient did improve to 6/36. This is the pre-op and post-op OCT which are compared. Another patient who had similar kind of pathology, you can see the posterior pole staphyloma, but the same technique we could achieve this result. This is yet another patient, lady actually, who had this macular detachment, and postoperatively same procedure yielded good result. This is story of another lady actually who underwent twice or thrice, this vitrectomy, apparently could not flatten ultimately, and ultimately this was the picture pre-post. And at the third surgery, once we did more ILM and massage the macular hole, we could. But ultimately, this patient did not do well from vision point of view. Vision was stuck at 5/60 only. This is another patient who has a lamellar kind of macular hole, but vision was very good in the right eye. So I didn't do anything. I just followed up this patient, and vision was being maintained. This is another patient who had progressive increase in symptomatology and a posterior pole detachment related to this, and with the gas and the same technique, we could flatten this retina, and patient did improve the vision also. This is my last patient who had posterior pole detachment and 3 surgeries already done. So at the last surgery, what I did was, at this small endo laser I did at the edge of the macular hole. Small laser, I had put a couple of spots at this temporal edge, and finally after 4th surgery, this patient did flatten down, and believe me, this lady still had 6/24 vision. I'm not advocating that you should laser, but after 3-4 surgery have gone, short of doing a macular buccal, which I'm actually not used to doing much macular buccal, so I had that macular small laser done. I know a lot of reports are there on macular buccal for myopic macular hole and detachment. There was this large series of 26 patients where macular buccal was done, and this is another promising thing which has been advocated, and a lot of people prefer this also. And this settled in all the patients, and vision also improvement is there. So just to summarize, if you have a patient like this, so standard of care today is VR surgery with ILM peel, internal tempora, generally works pretty well with macular detachment. ILM peel sometimes may be an issue, especially in high myopes, may be more challenging because of the poor contrast, and therefore flap may be preferable. Macular buccal, I agree, is a very good option, and think I have to learn that. And occasionally, gentle laser at the edge of the macular hole, you may be forced to do. Thank you very much for your kind attention.
Thank you, sir. Very good videos. I think especially the one showing the second layer of vitreous coming out with triamcinolone staining. That's quite an eye-opener, which you might leave and burn your fingers. Similarly, also I see that if we are a little patient and allow some time, the vitreous also becomes hydrated, like they talk about cataract getting hydrated. And I find that after a few minutes, we are able to see and remove much more vitreous compared to in the beginning part of the vitrectomy. I'm not sure if everybody can share that.
You're absolutely right that once once this is not happening, we pass time and doing vitrectomy somewhere else,
and then you come back,
and then you see that gets hydrated and.
So that was very good. One more point is, as you mentioned, sometimes we are desperate to attach the retina, even if the macular hole is there, and you had resurgeries, redetachments. So now what we are doing is putting fibrin glue over the macular hole and using a mid-peripheral hole for drainage, so that the retina attaches even though there is some damage from the glue at the macular hole. But as you said, massaging the hole or doing laser, you can put fibrin glue there
I
instead.
do not have much experience with fibrin glue. Maybe Mudit or other people can tell any experience with uh, fibrin glue placement over the such resistant kind of patients.
At least the retina gets attached.
Yeah.
Yes.
Yeah, I
Yes,
agree.
Mudit.
Retina gets attached.
We have used fibrin glue over macular holes.
Mike.
Sorry. Yeah, we have used fibrin glue over macular holes. It acts a very nice tamponade. So basically, essentially, then it prevents any fluid from ingressing in again.
Yeah.
So that way it works very well in these cases.
Vision improvement because patient keeps
Vision improves
Yeah.
actually because retina attaches at least. So
Yeah.
there is a peripheral vision.
Yeah, yeah. Some field definitely will come back.
The other thing is that while peeling ILM for macular hole RDs, you can do under PFCL. If you're not using PFCL, then a thing to do is to remember to peel in a direction away from the disc, because then the disc acts as like a counter traction. If you're peeling towards the disc, then the entire retina tends to get lifted again. But if you're peeling away from the disc, then that sometimes becomes slightly more easier than the opposite direction.
The reason which keeps bothering me is that suppose there is a detachment of the macular hole, and we know there is a gap between photoreceptors and rest of the retina.
Exactly.
And you pull it, you are increasing that gap.
Exactly.
So that's what I'm not fond of. Therefore, if we flatten the retina and then do it, then it may be making more physiological.
Dr. Shanmugam, any points on this? Dr. Tinku?
Nothing, very nice videos and nice presentation. Sometimes in a recurrent hole, either other than a macular hole, other than a macular buccal, one other option is to do a temporal scleral imbrication. So instead of pushing the sclera in, we can do a scleral imbrication that flattens the posterior staphyloма, and that can also close the hole.
How do you do that briefly?
Temporarily, we make a cut down about like mid-quadrant to mid-quadrant and raise a scleral flap about 6 to 8 millimeters. And at the base of the flap, take the sutures and shorten the sclera. So temporal sclera is shortened so that in anteriorly, close to the muscle ring, so that flattens the staphyloma posteriorly.
Tinku, anything you want to say about macular hole RD?
So sometimes in a lot of long-standing RD, especially, these macular holes are detected incidentally. Like you've not preoperatively, you may not be able to see them. You have a break somewhere else, and then you detect these. So, I mean, I think intraoperative OCT would help in such situations. And you should be prepared. You should be prepared to see, like, if your retinal detachment is not corresponding to the location of your breaks, then you should keep a macular hole in mind. So there could be a macular hole along with a peripheral break as well.
Yeah, that's a good
You
point.
see, first of my patient was that only. I was
Yes,
telling you
yes,
story of that
yes.
commissioner. You know, since that day, I have doing OCT in all patients because I
Yeah.
don't want to miss. And all of them are high-profile patients and they want result immediately. So OCT, you rightly said, is a must in all patients to rule out or rule in macular hole.
Thank you,
Thank
sir.
you, thank you.
So you can come on here. Dr. Mudit Tyagi, please.
Can I please have my slides here? All right, so good afternoon, and first of all, let me thank the scientific committee and Dr. Malika Goyal for having me as a part of this session. So I'll be talking about managing peripheral membranes in hypotony. But before we go to managing membranes and hypotony, we do need to understand what exactly do we mean by hypotony and how does it affect us, what are the different types, and what's the reason why that hypotony occurs, so that then we can understand how removing membranes helps in taking care of the pathogenesis and the problems that happen. So hypotony essentially is low pressure, which may be transient, chronic or permanent, and which leads to functional and structural changes. Can be acute as well as chronic. Acute is seen usually immediately early post-operative and usually can be related to surgeon-related surgical factors, is often reversible. If it resolves within 15 days to 1 month, it's termed as transient, but it usually does not cause any irreversible functional loss. Now, when do we label a hypotony as chronic? You do not have any absolutely well-defined definition, but an IOP of less than 5 for more than 3 to 4 weeks is what we label as a chronic hypotony. And how common is that? In the silicone oil study, they found that around 24% of eyes had a chronic hypotony, and another study, the vitreous study, showed around 18%. So chronic hypotony does tend to occur, and we need to understand why this occurs. Now, what is the reason or what's the pathogenesis behind a postoperative hypotony? It can be an increased outflow, in which case, like there's an improper port closure, or a scleral perforation or a necrosis that can happen sometimes post-inflammation. So you need to take care of that. There can be internal fistulization, there can be an outflow into the suprachoroidal space through a cyclodialysis cleft, and this is now what we need to remember. So remember this point, development of a cyclodialysis cleft, that is the other thing that can happen. Apart from that, there can be retinal detachment. So peripheral retinal detachments. So you may have a retina which is attached to the posterior pole, but you may have a detachment beyond that. So you may have put a belt buckle, and what you may see is that the posterior pole, the retina is well attached, but the peripheral retina beyond the buckle or beyond your laser marks may be detached. Now that is a cause of concern, because not only will that lead to a post-operative hypotony, it can also in future predispose or lead to neovascular glaucoma, peripheral neovascularization, and an NVI developing over there. So if you see an eye post-detachment developing an NVI, please suspect a peripheral residual detachment in the extreme periphery, which is the one which is leading to all of this. Inflammation again is one more cause. So this was one patient in which there was this large area of bare RP, and that in itself can lead to it. So bare inferior RP in eyes where we do an extensive retinotomy in itself can lead to inflammation as well as a subsequent hypotony. So that is another reason why some of these eyes do develop hypotony. And this was, like I was said, this was a case which was referred to us, and when we saw, you can see these laser marks, and the retina, while it's attached to the posterior pole, the entire retina in the periphery is lifted up, and that again can lead to subsequent hypotony. Apart from that, there will be a damage to ciliary body and a chronic traction at the anterior vitreous base, again reasons for leading to hypotony. Now where do peripheral membranes come in this entire picture? Peripheral membranes essentially lead to all of the points that we have discussed till now. They lead to an increased incidence of peripheral retinal detachments and recurrences. They can cause a traction and lead to ciliary body detachments. They can cause an inflammation, and they can in the long run lead to a ciliary body shutdown, which can also happen because of the combination of all of the other factors that we have discussed till now. So let me show you one case and how removal of these membranes can help. So this was a patient who had undergone a retinal surgery elsewhere, was referred to us. This patient had also undergone a silicone oil removal in November last year. But post silicone oil removal, while the retina is attached, the patient is maintaining an IOP of just 3 millimeter. The visual acuity is 20/600, and if you look at the OCT, you can see these entire areas and these extensive retinal folds over here. So this is a patient who is having a persistent hypotonic maculopathy which is happening, and this is an eye which is not likely to recover unless and until we take care of the hypotony that is happening over here. We did a UBM. Now UBM becomes an extremely important tool in a lot of these eyes, which helps us see this extensive peripheral CDs over here and this detachment that has occurred in this eye. So let me show you what we did. So this is a patient, so we went inside, started removing a lot of this peripheral membrane, and now if you look over here, you will see that there are these thin sheets of small peripheral membranes and these bands over here. You need to take care of these membranes. So Dr. MPS sir had shown a video where you could indent, and by indentation reach all the way up to the pars plana and remove these membranes. So see these membranes. And now you start indenting and you start seeing all of these peripheral membranes. So a lot of times you can indent, but a very valuable tool in these eyes can be endoscopy. So now we have started utilizing a lot of endoscopy, which allows us a visualization. So in this case, I was able to visualize, and then with the help of an endoscopy assisted visualization, you can take a scissor inside or a forceps and try to cut and remove all of these membranes. So even if you can't extensively remove all of this, even if you truncate it, you are relieving the traction. So truncation of all of these peripheral membrane bands, or if you can possibly peel them all off, then that helps. In the areas where there was a detachment and cyclodialysis, what we also did was we did a cryo. How does cryo help in some of these cases? Cryo leads to inflammation, and that subsequent inflammation also sometimes helps in closing some of the cyclodialysis clefts. If that doesn't happen, then sometimes you may have to go for a cyclodialysis repair also subsequently. This was another case. These are videos which I took from Dr. Rajiv. Again, in these cases, again, we did an endoscopic visualization, tried to remove all of the peripheral vitreous which was left behind, and then subsequently with the help of a cutter or even with the help of a scissor, you go around truncating or cutting a lot of these extensive peripheral membranes. So removal of these peripheral membranes becomes important. Subsequent to removal of the peripheral membranes, in the previous case, what we did was we have again injected 5000 centi-stroke oil, because we need to keep that in so as to ensure that the hypotony goes away. The patient on the first post-operative day is maintaining an IOP of 11. 1 week later also was maintaining an IOP of 14. We are still awaiting a long-term follow-up to see how the eye evolves, but the vision right now is 2400. not much of an improvement from 2600 to 2400, but too early. But essentially the IOP has started building up now in that eye. So in a nutshell, post-operative hypotony is a challenging condition. You need to have an individualized approach. You need to see what is the reason for the peripheral hypotony to occur. If it's a peripheral detachment, you need to take care of that. Removal of peripheral membranes becomes important because unless and until you remove those peripheral membranes, the underlying cause of that hypotony is going to persist. Thank you so much.
It's very good. So basically, UBM and endoscopic surgery are key to managing this case.
Yeah.
Dr.
The
Mohit
essential
Dogra will
thing
make.
is a visualization of the periphery. If you can indent and then see, then also it's important. Till we had endoscopy, the only way we were doing was we were trying to indent, and remove as much of peripheral membranes as possible. Because now we have endoscopy, it's made life slightly more easier.
Yeah, that's right. Dr. Mohit?
Great talk, Mudit. Just had to add 2 points regarding cyclic membrane removal. So peripheral membranes, absolutely, as you said. But I think once you get down to cyclic membranes, pre-op UBM is a must. And 2 things. If the media is clear, in my mind, because I do, unfortunately, more than my fair share of these in these young pediatric uveitic eyes, deep anterior self-scleral depression gives you spectacular view. Much better than what you can ever get, even in superb hands like Dr. Rajiv, better than that. If the media is not great, separate story. But I think we must trifurcate the presence of cyclic membranes based on 3 different etiologies. So uveitic eyes can chronically get cyclic membranes. Post-penetrating injury eyes can get, neglected cases can get, and multiple VR surgeries ones can get. Yeah. So typically your post-uveitic eyes will not be as vascular as they will be fibrotic. So actually removing them is more challenging, but bleeds less. So it's more like a TRD, which is not as vascular. The ones that form post-endophthalmitis or post-multiple VR surgeries are very vascular. So removing them becomes, is a big issue. They bleed a lot, and there actually trying to get them off becomes extremely, extremely difficult. There you actually need to just try and truncate, and if you can get one quadrant free, you're good. Because, if you were to look at your glaucoma people, when they do DLCPs, they will try and ablate 3 quadrants, leave 1 quadrant, and that is good enough, that amount of viable ciliary body for the eye to do what it does. So if we can get 1 quadrant free, maybe try and look at 2 quadrants and get a few of those ciliary processes free, I think we are able to get the eye out of that vicious cycle of hypotony and breathing again, so to say.
Yeah, so that is what, so in eyes where you're not able to peel the entire membrane, a good thing is to just go truncate. Cut in 2 or 3 areas. That essentially relieves the circumferential traction that is causing all of those subsequent points.
Mudit, Mudit. So great talk. So any role for methotrexate in these eyes?
So methotrexate works usually in preventing PVR. These are membranes which have already occurred. So like what we had discussed earlier, the essential thing in these eyes is to remove the membrane, because the membrane is the one which is causing all of the subsequent problems. Methotrexate will essentially reduce probably the incidence of PVR that is there. But the essential etiology behind why all of this is happening is because of the membranes. So you need to take care of those first.
Okay.
Yeah.
Thanks.
To be honest, I have not tried methotrexate in these eyes.
Thank you.
Okay, I think in time we'll move on. So this is the last talk of the session, and then if there is any time, we will have a discussion on Dr. Tinku's talk also, which was also on PDR. So most important, I feel that we should know is when to operate and whether even to operate. So if we see patients like these, which are relatively stable, vision is good, there's nothing to be achieved by immediately operating, just doing good laser, and these patients more than 10 years old with stable retinas. Similarly, this patient is not even aware of any problem, 6/6 vision, advanced PDR, so just laser and no surgery. Despite the macular traction, there's no indication for surgery. More complex cases like this, only the macula is attached. I think the vision is good, 6/18, so it might be good to wait and watch rather than operate and then give them zero vision at the end. So we just observed this patient, and in a few days there was a detachment at the macula, and that is when I intervened. And we tried to initially just minimize the surgery by doing traction relief and left it at that. And many times this works. The macula remains attached and we can just do laser. However, in this patient, it did not, the macula did detach subsequently. So under oil itself, as was in one of the other talks now, it's good to remove the membranes while leaving the oil inside, because oil keeps the macula, the retina flat, instead of allowing a bullous kind of detachment. So membrane peeling is safer, and also it does not allow bleeding to disperse, so our view remains clear. And once we have done a significant amount of membrane removal, then oil can be removed to allow vitrectomy to go in. But at least most of the membrane peeling, as far as possible, is best done under oil. Now, once we've decided that we have to operate, even then as much laser as possible should be done. And not only before surgery, but also during surgery, as much as laser as possible, and post-operatively as well. Pre-operative anti-VEGF is very important to give a good view, but there is a single most important disadvantage, and that is we cannot see the breaks during surgery because they don't bleed. So earlier we used to have, without anti-VEGF, this type of picture where we are not able to see because of bleeding. But now, though there is no bleeding, the other problem is if you see there is a break here, but it doesn't bleed. Similarly, there's a second break here, but it has not bled. Again, a third break. So we have to be very careful we don't miss these breaks. We identify the breaks and keep diathermizing them, because they won't be seen later on. There is no bleeding. So that's a major disadvantage of anti-VEGF use, pre-operative anti-VEGF. And when there is some space between the retina and the tissue, it's good to just go with a vitrector in the cleavage plane, the vitrector facing anteriorly, so that the retina is not caught. But where there is no space between the retina and the tissue, there the vitrector faces posteriorly to be able to shave the tissue off. And it's not necessary to remove all bit of tissue, fibrous tissue. It's okay to release the traction and leave areas which are relaxed, and then attach the retina. And most of the time this works. Now, sometimes when we try to do a blunt dissection going between the retina and the tissue, you can have these kind of major breaks. So this kind of blunt dissection has to be avoided if the retina is very thin around the area of the glial tissue, and if the adhesion is very strong. There you have to go with sharp dissections. So here you can see the two breaks caused by lifting the retina. So if the retina is thin or the adhesion is strong, then blunt dissection doesn't work. Sometimes we have this kind of bleeding, especially if anti-VEGF has not been used preoperatively, and you have some breaks which we cannot laser because of poor visibility or the blood. There we have started using fibrin glue. The two components are instilled sequentially over each break, so that the breaks are closed and you get a good result. Similarly, if the break is very close to the center, as here, then you can just put glue over the break, this break, and you can see that the retina hole is closed by the glue and retina is attached. ILM peeling wherever possible should be done, even in PDR, because it gives a very good post-operative view, as you see in this OCT picture. The post-operative foveal restoration is fast. The visual quality is much better. Only problem is that the ILM peeling in PDR is more challenging. The ILM I have found is to be much more adherent to the retina. So it takes much more time, and it may be just piecemeal. It may not be a complete ILM peel. But it's important not to go very aggressively over the center and create a macular hole, because that would be a different problem then. This is how ILM peeling helps. Within a week or two, you get a very beautiful contour, and the visual quality is definitely much better with ILM peeling. Now, during surgery, if we have bleeding, you should not allow it to clot. Use the reflux from the vitrector to raise the blood and aspirate. So keep on using these alternately, the reflux and aspiration, so that the blood is not allowed to clot over the surface, and you can still get good result. This is in earlier days when we were not using anti-VEGF. If there is a clot, leave it with oil, face down position, the retina remains attached, and then you can go and remove the oil after 2 weeks. As you saw, it came out very easily because by now it has clotted. So there is no rebleeding. And again, under oil, we can do resurgery. And If there is bleeding, it can be removed easily because the blood is heavier than oil. It settles at the most dependent part and it can be easily aspirated. Sorry. All right. And the last part is that most of the time we focus on the posterior vitreous, but a thin sheet of anterior vitreous is left behind, which holds the blood. And if you find most of these cases, you just remove anterior blood and the posterior vitreous was already clear. So you have to make a special attempt to remove the anterior vitreous first before we go to the posterior vitrectomy. Also in PDR cases, I prefer to leave oil because it gives us a good view to continue the even if tamponade is not required or gas might work. Because gas does not allow a good view for pan-retinal laser post-operatively, and also the visual rehabilitation is very good with oil from day one. Even if there is bleeding post-op, it remains limited to the lower quadrants when oil is in place. So the media is clear, it allows us to examine and laser, and patient's vision remains good. It does not allow the blood to disperse. Persistent SRF is common and should not be a reason to reoperate. You can just monitor it serially and you can see that the SRF is reducing over time and resolves. Unless there is an open break and there is no laser around that area. So thank you very much. I think now we can have a couple of minutes of discussion with Dr. Tinku's talk and mine. Anything from the panel or from the audience?
Dr. Malika, you very well highlighted the point that peripheral membranes, I mean, we don't have to be too aggressive and remove all the membranes. Some peripheral membranes, if they're small and if they're very tightly adherent, can be left behind. Rather than risk creating a nitrogenic break, it's better to leave those small membranes behind.
I think every membrane or tissue, we have to see how much it's contributing to the detachment and whether it will continue to contribute. If it will not, then I think it's best left.
So then we can leave that alone.
One of the things is, as you mentioned, the bottle height. I think you had mentioned in your talk. So if you're not careful, sometimes you see there are central retinal artery pulsations. So look for those, especially in diabetic eyes, they're already ischemic. So I found that sometimes these eyes become very pale, the disc becomes very pale post-op. So very important to see that the perfusion is maintained during surgery and also during fluid air exchange, etc. We don't traumatize the disc too much by repeated touching over the disc, because there can be a lot of trauma to the disc, ischemic or mechanical, where we are focused totally on the retina, but visual outcome can be poor.
Also, in a case of TRD, do you attempt to drain the fluid? You showed the last OCTs that the fluid does come down over a period of time. Do you ever attempt to create a retinotomy and drain it?
Only if the fluid is increasing over time, then you know that there is a break somewhere. So only if fluid is increasing with time, but if it is the stable or reducing with time, it doesn't need removal.
No,
Yes,
on table.
No, but if you are sure that you do not have a break, it's just a traction, these eyes will be lifted because of the fact that there was a traction. But now that you have removed the traction, there is no break, you can just leave it because over a period of time it will flatten down.
Yeah,
But
so that's
break,
what I wanted to highlight. There's no need to drain that tractional fluid. It will come down on its own over a period of time.
Also like to highlight two articles for, I think, everybody in general. I think from a lot of the surgeons who are here and even otherwise prolific surgeons from the country. 2 years ago, we got like a Delphi statement out on like a semi-consensus from surgeons on surgery for proliferative diabetic retinopathy, in which some of these questions were tackled, and there was a level of evidence which was given. So this is an IGO and goes by the name of a Delphi approach with outcomes of surgery for proliferative diabetic retinopathy. I would strongly suggest, go through that. Lots of experienced surgeons of the country contributed in that. And also recently, a review article on MIVS in proliferative diabetic retinopathy in IGO a couple of months back came out, spearheaded by the AIMS group. And I would strongly urge people to go through that. I think a lot of what was discussed regarding diabetic retinopathy, especially PDR surgery, has been collated very well in those articles.
Yes. Take the mic, can you? Here.
systemically optimized.
Can you speak into the mic?
Sometimes our patients are not systemically optimized to be operated as soon as possible. So we have to wait for 3 to 4 weeks. And can we do lasers of the unlasered areas in macular TRDs also before surgeries? Yes.
Even if the patient, I would say, is optimized for surgery, I would suggest that if you can pump in laser at that time, you should. Also, mind you, if you have someone who let's say does not have a TRD, is let's say a patient who has very severe, let's say a premacular bleed, and you feel कि ये तो relatively easy case होगा, unlasered, but has CKD, and you take this patient, you get fitness, you take this patient up for surgery, the patient is not lasered, and you pump in a lot of laser at the end of surgery because typically no membranes to be removed, surgery went off fine. So what you do pre-op when you do, PRPs, you do it over sessions. Here you're pumping in a lot of laser at the same time, and especially in CKD patients who have fluid overload and who might not be able to, have their regular twice or thrice weekly set, dialysis because of surgery on a particular day. They can land up in first or second post-op day or third post-op day with huge amount of exudative retinal detachment to the point that people think that it's reg RD, but it's not. With a lot of fibrinous reaction, and that's all laser-induced, and what you have done. So please, if there's an opportunity and the media is permitting, pump in as much laser as you can beforehand.
And second question, in many conferences, they prefer gases over oil. In our practice
Can you speak
also
into the mic? I don't think it's audible.
in many of the conferences, many surgeons prefer gases over oil in modern surgeries. But in our institute too, we go for oil. What would be a threshold to select oil over gases, or should we keep the threshold low in PDR cases?
Dr. Shanmugam, you want to speak?
There is no threshold to say that what it is. So if you have removed all the membranes adequately and there's just a superior break, then you can leave it with air also is adequate. Not necessarily all the time it has to be a gas. But a complicated case with inferior breaks, and of course the ideal situation is you remove all the membranes in diabetic patients. You leave behind anything, oil is not a substitute. So ultimately the breaks will lift up. So you need to remove all the membranes. And if it's a one-eyed patient, which is often the case in diabetic patient, then again you will use oil. So there is no, so if you go to the West, people will keep saying use gas, but the type of cases they manage is different from what we manage. So more often we would be using oil, but depending on how simple or difficult the case is, the threshold will vary.
Thank you, sir. Thank you.
And if there are no more questions, we can wind up the session. I'd like to thank the panelists and the audience for their patience. Thank you very much.
Thank you.